Good afternoon, everybody. I'll invite you all to take your seats for the final session of Future Trials 25. We will be no doubt full of energy after that incredibly healthy lunch that we've all had. So we'll keep up our energy for all of this afternoon's speakers. We're going to start with another short video. When the team put out a call for patient representatives, Luna Mata-Cervera replied immediately. Luna is a research nurse at the Clinical Research Facility here in Galway, and she, along with Dr. Michelle O'Shaughnessy, has an incredible relationship with her patients, and she knew that two of their patients would be happy to tell their story. I think it's been really clear that today would not be complete if we did not acknowledge the contribution of trial nurses, pharmacists, and all of the patient-facing personnel in clinical trials. So here is Luna and her patients.
The Origin 3 study is a phase 3 double-blind placebo-controlled study of atacicept versus placebo in patients with IgA nephropathy. So IgA nephropathy is an autoimmune kidney disease. It's a disease that typically presents in people in their 20s, so younger adults. It can be a silent disease. At least patients initially can have very few symptoms. And it doesn't cause kidney failure overnight, but we know from some recent data that the vast majority of patients without treatment or without effective treatment will go on to develop kidney failure during their lifetime within 12 or 14 years. Up until recent years, there was no licensed therapy for IgA nephropathy. So, this is a study of a drug that's given under the skin once a week. The patient gives it themselves at home, stored in the fridge, and they give the medicine. It modulates the immune system. So we say that it doesn't suppress the immune system, but it changes the way B cells develop. So it reduces the production of these abnormal IgA molecules, or specifically galactose deficient IgA1 molecules. And in doing so, it reduces the deposition of these molecules in the kidney and the associated inflammation and the associated damage, and therefore protects kidney function. Your kidneys are slowly decreasing in the background without you even knowing until all of a sudden you could potentially be in a position that's quite life threatening. It ended up that I was on the highest level of treatment that there was, but there's nothing more that they could do for me. So that's when I found out about the trial. It's great to know that you're being looked after by a well knowledgeable team that know about your disease and understand what you're going through. Without people putting themselves forward to be on the clinical trials, a lot of drugs wouldn't be licensed, and life-changing medication that really, really impact people's lives. So it's very important for people to take part and be a part of that journey to ensure that the next person who really needs the medication, it's there for them when they need it.
One of the things that motivates me most about coming here into work and meeting one of our participants would be to be able to help someone that has no treatment for a disease, that doesn't really understand how their disease works. I really want to understand what you're feeling. I really want to know how can I help you, be able to be there for you.
So I was diagnosed with IgA nephropathy when I was 14 years old, but I didn't understand the gravity of my situation until obviously I was much older. I was still very young. As time went on, I started to look into more treatment and possible even treatment abroad as well from Ireland. But luckily, this drug trial came as an opportunity and I pounced on it, of course. And ever since then, I started taking the drug and I definitely feel significantly better since. I would definitely say that the drug trial has without a doubt, improved my condition. So my dad moved to Ireland. He's from Iraq, but unfortunately, 4 years ago, he passed away from kidney failure. Like, my dad was probably one of the most sickest men I've ever known, but one of the strongest as well. If he was here today, he'd tell me to look after my health for certain. So that's why I want to do it as much as I can. My dad did not have the opportunities that I do. That is definitely something I want to take advantage of, and I want to carry his morals and his guidance along with me. But personally, for me, it's the best decision I ever made, especially for my health.
Thank you to Luna, Amy, Michelle, and Dara for sharing their story with us. Our final session looks ahead to the future of trials, AI, Decentralized models and personalized care are not just trends, they are reshaping how we design and deliver research and trials. We begin with a keynote address from one of the leading figures in innovative clinical trial methodology, advancing study design, conduct, and analysis. Professor Palmer is a leading expert in the effective translation of scientific research into patient benefits. So please give a very warm welcome to Professor Max Palmer, the Director of the MRC Clinical Trials Unit at University College London.
Thank you very much for that kind introduction. Thank you very much for the invitation to come speak to you today. I'm going to talk to you for about 20 minutes about improving health by improving trials and why do we need to do that. I'd like to argue that we need a step change in our design of clinical trials. Those of us who've been in clinical trials for a few years now, looking around, there are one or two of you at least in the audience. We know that the development and testing process is too slow. We often, when we get to the end of a phase 3 trial, we often show that the new is no better than the standard, so we've got no further. And in many diseases, what has changed is that we've got many new therapies to test, and actually we've made very, very slow progress over many, many decades. As I say, in some diseases, we've got many new therapies to test, and that really is a big change over the last 15, 20 years. And again, for those of us who do trials, the process, the timelines between stopping an old trial and the gap between that and the next trial is enormous. It takes forever. And we need a step change in that efficiency. We can't tinker with it. We need a step change in it. And one of the motivations for this is to think about the diseases in which we've made little or no progress anywhere in the world for decades. And I've just given you an example of some of them there, a number of cancers, a number of neurodegenerative diseases is there, advanced lung and kidney disease, and mental health condition, infectious disease like flu and RSV. How long has flu been around? How do we still have no idea how to treat it? So a key part of the solution to some of this step change has been these idea of platform trials, master protocols, and you'll all be aware of that sort of general idea. And there's lots of designs that come under that general umbrella of platform trials, master protocols. And actually, the principles are really quite simple. They're really very, very simple. The principles, the common element across all of those designs are that many primary hypotheses in one protocol. So you're asking many questions rather than one, which is, if you go back to when you've learned about statistics and medical statistics and trials, you only ask one primary question and you answer it. Well, no, actually, you don't. You do it differently. And what you do, again, differently to what you've learned, is you adapt the trial as you go. You might drop some interventions, you may add further interventions, you may change the nature of some of those interventions, you may change the population that you're looking at. So you change the trial as you go. And the problem has been, though, all of these solutions that have been developed, many of them have been developed for phase 2 and applied to the phase 2 setting. My own view is that it's completely misdirected and actually will only progress us in a small way forward. And I'll explain why in a bit in this presentation. I'll talk particularly about multi-arm, multi-stage platform trials in this presentation. And again, the principles are very, very simple. What you do is you evaluate many interventions in one protocol. You include a phase 3 stage as well as a phase 2 stage. You acknowledge that many of the interventions will not succeed. We know that. From history, we know that. We're just hoping that some of them will succeed. And you adapt the protocol as you go. And this is the general idea behind these designs. The traditional approach is shown at the top of that slide there, where you have a control versus treatment. You do a 2-arm trial, and then you do the next one, and then you do the next one. And we've shown lots of failures in that way. It's a very simple idea of bringing all the treatments starting together against control, one control arm, treatment A, treatment B, and treatment C, and at a point in time you add treatment D to the mix. So a very simple idea. Why include the phase 3 component as the last stage? Well, if you look at it, actually, in most diseases that we see that we've seen lots of phase 2 signals activity. What has happened is those phase 2 signals of activity not translated into improvements in phase 3 outcomes. And so failure is often at a randomized phase 3 stage, and most, if not many, phase 3 trials do not really show superiority. And allied to that, the phase 3 component is the most expensive part of the evaluation. If you talk to our industry colleagues, it's about 75% of all the costs of evaluating a new therapy. So that's where the action is, that's where the money is. And for those of us who do phase 3 trials, you know they cost many, many millions, if not hundreds of millions of pounds, whatever currency you like. And they take many hundreds, if not many thousands of patients, many, many sites, and disturbingly many, many years to do. And Parkinson's disease is a very good example of the challenge we have. We'll all know somebody with Parkinson's. You'll all know somebody with Parkinson's disease. We know that this is a horrible disease, and what this graphic shows you is all the phase 2 trials that have been done, or a number of the phase 2 trials that have been done in this area, in the brown blocks, followed by a gap in time, followed by the yellow blocks, which are the phase 3 trials. Lots of phase 2 signals coming out, no positive phase 3 trial showing any disease modification at all. We have no disease modifying treatment for Parkinson's disease. We have only got symptomatic treatments, and we know that, despite absolute decades of work. When we're doing these sorts of trials, and I'll show you an example in a minute, what you can do actually is plan strategically. So plan strategically, because we've got so many new therapies to evaluate, in your research arms, choose research interventions with different modes of action. 2 reasons for that. One, you maximize your chance of success, because if one mode of action does work, then it's pointless having the same sort of mode of action, just with another agent in that trial. You're better off evaluating another mode of action. The other thing that you can strategically plan for, if you think about it, if you think about all of the major diseases that we treat these days, by and large, there's very, very few of them that don't need combination treatment to get a cure or get a significant improvement in outcome. Very, very few of them. So we know combination treatment is going to be our goal. If you test many different interventions with different modes of action, you can potentially combine them. So you jump ahead. And there's a statistical reason for doing that as well, which I won't talk about today. So I've given you some basic principles here. Let's show you an example of some of these. So the first formal multi-arm multi-stage platform trials in the modern era, I say the modern era because if you actually go back, there's a TB trial in 1952, which was a platform trial done by Bradford Hill and others. But I guess there's nothing new under the sun is there. But in terms of the modern era, these started in about 2000, 2005. We started Stampede in prostate cancer, which is a randomized phase 3, 6-arm, 3-stage trial launched in 2005. The first discussions about adding arms was in 2007. It morphed formally into a platform trial, i.e. adding arms in 2010. And over that time, since 2010, we've added 5 new research arms. So we've had 10 research arms being evaluated within that trial. At about the same time, groups in the States who were looking at breast cancer, looking at the iSpy design, was a randomized phase 2 platform launched in 2010. So these things started around sort of late 2000s, close to 2010. So let me try and make this real, give you a specific example. Stampede was a trial in prostate cancer, about 1 million new prostate cancers worldwide. And in 2005, when we started this thinking, standard treatment for high-risk prostate cancer had not changed for 40 years. Hormone therapy was the mainstay, and that's all we had. We had not moved the dial on that at all. Median survival for men with metastatic disease was about 3 years. So pretty miserable outcomes. So we started this multi-arm, multi-stage phase 3 platform trial in prostate cancer. And over that last 20 years, we've evaluated a chemotherapy agent, bisphosphonate, a COX-2 inhibitor, radiotherapy, the new ARSIs, androgen receptor signaling inhibitors, metformin, and estrogens as treatments. They include old drugs, new drugs, repurposed drugs, and non-drugs. This is the design of the trial. You don't need to pay too much attention to this, except the top line shows you the control arm, the blocks show you the accrual, the dotted line shows you follow-up, and the black box at the end shows you the point of analysis. And you can see the control arm goes right across from 2005 up to the present day, and you can see all the other arms, all their recruitment and their time points of analysis at various points in time. And so this is the sort of bottom line of all of that 20 years of work. 12,000 participants from 120 odd hospitals in the UK and Switzerland, 5 changes of standard of care, 4 as a consequence of Stampede itself. So the results from Stampede emerged and we changed standard of care as a consequence of that and fed that back directly into the protocol. And we can discuss how you can do that. And most importantly, of course, as a consequence of the results of Stampede and other ongoing trials, which came together at about the same sort of time for those questions, the survival now for men with metastatic prostate cancer has moved the dial from 3 years median survival to 8 years median survival. And if you think of any other way you might do that over a 20-year period, I can't imagine any other way we would have done that over a 20-year period. If you tested those individual agents in the usual way, we would have probably taken a generation, maybe 2 generations to evaluate those therapies. Once you start thinking in this way, you can do lots of things. We've dropped research arms within Stampede. We've added research arms. We've changed, as I said, the control and research arms by results from the study itself. We've changed the primary outcome measure because of external data. We've changed the sample size. We've split the population into subgroups of targeted therapies. So you can see, actually, adaptation can be very widespread. So we've taken this sort of thinking further on. I'll just show you another example that we're now starting off with. Those of you who are surgically inclined will know that after surgery, wound infection is a major issue. And if you think of all of the surgeries that go on in the world, for all of the various conditions, it's a huge problem worldwide. It's a major issue for the patient and a major issue for health services. And actually, there's been little or no work in being done on how we can reduce the wound infection rate. Even reducing it by a small amount would really shift the dial internationally. And the recommendations that I've got for this are very poor evidence base, and only generic guidance is available. So can we do something a bit better and do something a bit more quickly than we might previously have done? In a more structured, strategic way. So what we've done is design multiple parallel, separately powered multi-arm, multi-stage platform trials across different specific body sites. Have just one single protocol for all of these. So this is for those who like the names, this is a basket factorial multi-arm, multi-stage platform design. And this is the design. So there's a basket in breast disease, breast surgery, vascular surgery, cardiac surgery, neurosurgery, amputations, and thoracic surgery. And we're trying a number of interventions, 8 in each. Some of them overlap across different surgical interventions. And as we learn from one surgical setting, you can then, if you've got a successful result, you can translate that to other surgical settings. And if you get a negative result in a surgical setting, which is recruiting quickly, that might influence what you do with that same intervention in other surgical settings. So that is a very dynamic way of running these trials. That trial has just been funded by the NHR in the UK and will get started in the next few months. I'm always asked, what about industry and academia and platform trials? Well, actually, academia has got a major role in these platform trials. because industry is only going to be usually interested in one intervention for a given disease at a given time. Academia, you in the audience have got an opportunity to make a huge difference in this area by addressing these sorts of issues, because only academia will do these sorts of trials. And experience shows that. So I think we have an opportunity in the academic community to change the game. Industry, actually, if you do these things, actually wants to be involved. In Stampede, we've had 6 industry partners all along, and they've been involved in a variety of ways for a variety of reasons to help use the data from Stampede as an independent study to support licensing, extending an agent to this disease from other diseases, extending the population of the patients that are being treated through Stampede, because it's a very broad population. We were using overall survival as our primary outcome measure, so studying longer term or different outcome measures to the ones they're studying in their diseases. And we also had discussions as a potential pivotal licensing study. That hasn't happened in Stampede, but from some of the other multi-arm, multi-stage trials, we're having those discussions. Of course, not all trials can be like this, but I think we do need to think when you should prioritize such a strategy. And my own view is that you should prioritize such a strategy in those sorts of areas that I mentioned there, when progress has been slow, where we need to change the game of what we're doing. Otherwise, we'll carry on. Where we are with Parkinson's disease now will be where we are with Parkinson's disease in 40 years' time. And I don't think we can accept that. We also need a number of new interventions with different targets to be available. They don't all have to be new interventions. Repurposed interventions can be used. And of course, industry repurposes all the time. All the time. There's some sense that repurposing in the academic world is a bad thing. No, it isn't. You've got to get patients and enough doctors and researchers on board, and of course you've got to get the funders on board. And those are challenges in their own right. But these things can be done. There are more than about 100 of these sorts of trials going on worldwide in a variety of settings. Of course, the COVID pandemic was a good example of where a number of these trials went on, these sorts of designs. And we're making it a goal to help others develop these sorts of trials wherever they might be, and just a sense of all the different areas in which MAMS platform trials are being developed, and we're helping them develop them. Many of these trials we are not running. It takes quite a big engine room to run these trials, but the investment is more than worthwhile. But you can see they have broad applicability across a range of areas. I'll just finish by saying that I think there's a desperate need to make faster progress, certainly in a number of our major diseases, which have just been forgotten. And if we carry on the way we're going, we'll still be in the same place 20, 30, 40 years from now. Of course, they need widespread buy-in. They also need some strategic thinking, that you need to be in the game for a 5 to 20 year horizon, focusing on the phase 3 evaluation. Historically, what we've found is actually the researchers and the funders are the biggest hurdles in getting these things through. And perhaps we can open that up in the discussion. What's opened the door and opened the key on a lot of occasions has been the patient voice. And the patient partners who've been involved in these things have said, why don't you do all your trials in this way? And we still haven't got a good answer to that question. And I'll stop there. Thank you.
Thank you so much, Professor Palmer. We do have time for a few questions. So if you'd like to raise your hand, if you have a question, Professor Palmer. It's very bright up here. So if fantastic question over here. Get a mic.
Hi.
Oh, there. Yeah.
Hi
Sorry.
there. Hi.
Let's start here. Yeah.
I'm Catherine O'Connor. I'm from Regeneron. And I suppose I'm just wondering, I think what you're saying, you're sort of preaching to the converted here with your presentation. It was fantastic. But in terms of like attracting industry, like you say, each company is interested in their particular asset. How do we sort of make platform trials more industry friendly?
I'm not sure that we need to make them more industry friendly. I think they already are. I think especially if you focus on the idea that you will have generally in a given class only one agent, then the industry partners are not competing against each other, because ultimately we know we're going to go to combination therapy. They're just seeing what their intervention, their agent, adds to the soup. So we've not found it any difficulty.
That's fantastic. Look, I think it is. I think you're right. I think it's the way forward. I think we've got to get there faster. Thank you.
Thank you. I think we had a question at the front here.
Thank you for a very interesting presentation. I was just wondering if you could elaborate a little bit around the regulatory and ethics committee pathway, because typically when we do trials and we submit and we're being too broad on our objectives, we get a lot of pushback. So any comments?
It's interesting, and we thought the same, but actually, of the various different folks between funders, researchers, patients, regulators, etc., the two groups who've been most receptive to these things have been the patients and the regulators. They get it, and as long as you can retain the scientific integrity, show them how you're retaining the scientific integrity, they're fine, and they're easy relative to the researchers and the funders, and they're a pleasure to work with.
Professor Sir Royce, a question from you.
Any trouble with the statistician, because you have potentially multiple look at the data and different time to event? I mean, how do you handle that? Is there some objection from that?
Okay, so I should say I am a statistician.
Good.
So I'll divulge that bit of conflict of interest. And no, you're right. You're right. Some of these issues are quite challenging, but you can methodologically work through them, and you can show others, the regulators, peer reviewers, etc., that your scientific integrity is retained in your work. And we've been able to do that not only in Stampede, but a number of other settings. It does take quite a lot of work, but just think, actually, it takes months of work. Just think how many years of work we put into doing any individual two-arm clinical trial. It's modest compared to what we spend on clinical trials.
Thank you. I don't see. Oh, there's one more hand there. Yep, let's squeeze in one more.
Thank you very much indeed, Max. Andrew Murphy, General Practitioner. Just on the health economic side of it, have you any figures of the average cost per patient in multi-arm trials compared to others? Because presumably there's great savings to be made.
Yeah, it's a good question. You are right. We haven't done those calculations. I think some people are on to doing that. My own view, it's barn door obvious, isn't it? And why wouldn't you do this? And yeah, but you are right. It per patient it will be much less. There is as I wouldn't pretend that these are easy things to do, because as you've indicated in your question, behind the scenes there's some real challenges. But the prize is so big here. We as a community need to change the way we think.
Thank you very much, Professor Palmer. Thank you. Professor Seamus O'Reilly established the National Green Cancer Clinical Trials Initiative at Cancer Trials Ireland in 2022, with the goal of embedding climate awareness and sustainability into the organisation and into the design and conduct of clinical trials. We now hear from Professor O'Reilly on the work and initiatives in this space. Thank you.
Thank you for inviting me to speak today. These are my conflicts of interest. I'm a medical oncologist. The carbon footprint of what I do is estimated between 1 to 4 rocket launches a year, and that contributes to the healthcare emissions of healthcare climate emissions, which are the same as the continent of Africa every year. These are the take-home messages of my talk. First of all, climate change is here, and healthcare has a significant climate liability. What we do transforms lives, but how we do it transforms the environment and paradoxically impacts on human health. The clinical trials infrastructure and network is pivotal in making how we practice healthcare more climate efficient. And at many of our meetings, we talk about the language of patients. We've seen that as being a key component earlier. the language of artificial intelligence, I would argue that the language of planetary health is as important as all of those and necessary for how we practice medicine today and how we run clinical trials. This statement was made in the Financial Times last summer, and it was made because of the concern about the future of our children and grandchildren. And their future was outlined here in these works by some of the leading thought and literature leaders of our time. They outlined that in 80 years' time, summer would be 10 months and winter would be 2 months. And why did they make this statement, and why is this going to be our children's reality? And it's because of this, because we're living and we've created a triple planetary crisis. And we are temporal colonials in the planet, harvesting the resources for the future generations. How we work and live in Ireland requires 2.5 planets to sustain. Erosion by agriculture to date is 12 times greater than that caused by the glaciers during the Ice Age. So what does this mean for people in this room and if you're in the clinical trial community? So its impacts are multifaceted. The first thing is climate adaptation. You need to make your clinical trials infrastructure climate resilient so that the scientific integrity of your trial is not evaporated by a storm or by a flood. We also need to bring in climate mitigation in clinical trials, make them more climate friendly, less wasteful. Things like funding requirements. So when we write a grant, there's a forensic assessment of the financial implications of the grant and how many euros are spent on this and that and indirect costs. But the long-term environmental cost is not factored in at all. That probably needs to change. And finally, for a health caring profession, what are the implications for us in terms of our lifestyle and how we advocate in our communities? In 2022, we set up the National Green Clinical Trials Initiative in Cancer Trials Ireland to kind of look and try and get some foot in the door in terms of these issues. And we coined the term climate toxicity to demonstrate the impact of climate change on how we practice medicine, but also significantly how we practice medicine and what its impact on the environment, mirroring symptom toxicity, financial toxicity, and time toxicity. What we learned in this exercise is that when we looked at the clinical trials organizations globally, that climate awareness was low. But we also felt the opportunity was high. Professor Palmer has talked about large trials. So a 2,000 patient trial will generate almost 250,000 sheets of paper with 3 million data elements. And in the primary and secondary analysis, only 10% of those data points will ever be used. So there's enormous opportunity, some low-hanging fruit in clinical trials in terms of integrating planetary health. There's also an issue that many of our trials units are integrated with universities. That's evident here in Galway. And My Green Labs has been pioneered here by Dr. Una Fitzgerald of this parish. And in Ireland, we have the highest proportion of My Green Labs in our universities than anywhere else in the world because of this work. And that cascades. It cascades into industry. It can cascade into our clinical trials unit. It also has a role in terms of, in our clinical environment, we're adept at protocol development. We talked about COVID and how it has affected clinical trials. So we're agile. We need to be agile here as well. And this is reflected in this study here, where we looked at the compared academic and industry trials, where you can see with academic trials, you've more diverse data sharing, more biobank selection, more focus on optimization of care, which often involves less care. So as a medical oncologist, 60% of what I do transforms patients' lives, but 10% is harmful and 30% is wasteful. These clinical trials can make that 30% less, having more economic impact because we can use the money for other things in our society, but also less environmental and less patient toxicity in addition. We learned that unless you measure something, you can't manage it. And when you measure, you find things that you don't want to see. So this is a paper from BMJ. We were one of 10 trials. Fidelma and the group in Galway also had a trial in this paper. We had a Shamrock trial, so we thought we were going to be the best in class, but we were not. And this carbon mapping looked at design, beginning the trial, to analysis. And what you can see is that our footprint was terrible because our procurement went from Japan to Canada. And blue is patient visits because with very poor public transport in Ireland, everybody was driving to the clinic in order to get their infusions. So we really learned that while we might think we're brilliant, when we actually measure, we're less. But this also gives us an opportunity to harvest things, to refine things and reduce the carbon footprint of what we do. We learned that that if you digitize and decentralize trials, you can have a significant impact. So this study is from Berlin. And if you look at a fully digital, decentralized clinical trial, you reduce the carbon footprint of a study by 90%. And different hybrid models are vary compared to that. So how does that work, and how do you go into the weeds in this? So this is a trial from Singapore. And in Singapore, they looked at probiotic use in pregnant women to prevent postpartum depression. And this trial took place around the time of the COVID-19 pandemic. And if anybody was living in Singapore during the COVID-19 pandemic, they really knew how to do social distancing and protective isolation. And in this trial, then on the right-hand side, my left-hand side, your regular passenger visit, printed paper, couriers, web use, and paper waste treatment as a traditional model. And then you've got a decentralized one where we use the web, smartphones, couriers to eliminate visits and you also have waste treatment. And what you can see here on the bottom then is the climate change impact of a traditional and a hybrid trial are better, but a decentralized trial is dramatically less. And finally, on the right-hand side, you can see the disability adjusted life years per participant from the trial is dramatically less in a decentralized digital platform. But we also learned that the cloud is not climate neutral. So in Ireland, 30% of data stored in our data centers is healthcare related data. By 2030, 10% of Ireland's electricity consumption will be devoted to healthcare data storage in our data centers. And this is the newer data centers are also more powerful. So the largest announced will require the same electricity generation as 5 million households. And that's because of the development of these accelerated servers you can see in yellow here that are growing over the present decade. But when we think of data centers, we think of electricity, but that's not the full picture, because as you can see on the right-hand side, red is heat generated from the servers. Blue then is water that goes in to cool the servers. When we cool the servers, that requires drinkable water. So if you do a ChatGPT calculation today, that requires half a litre of drinkable water. And this is emphasized here in this exhibit from the Venice Biennale from Chile, looking at the interaction of data centers in the environment. Amazon aren't building data centers in Ireland anymore because our water infrastructure is not adequate to cool the data centers. And in 8 states in the United States, building data centers is incompatible with providing water to populations, and they've stopped too. So how do we change? So when we talk about climate change, sometimes you can say, God, he's virtue signaling. And then there's the thing of you're trying to catch a lion with the mousetrap. And then there's also in clinical medicine that we're caught up with the urgent, whereas we're missing the important. We think sustainability is low. It's also a perfect problem because unlike COVID, when COVID happened, everyone was terrified. It threatened society, everybody changed, and it was funded. Whereas in climate change, it's someone else's problem, and it might happen, it may be there, but it's a long way down the road. So it's the perfect problem in terms of that. And then our political climate doesn't help either, because we've had a growth of, there's a study in NPJ Climate Change where they show that liberal politicians are more likely to be climate aware than conservative politicians. And you know where the general direction is not going in terms of liberal politics at the moment. So how do you move the dial? So we did a survey looking at the Breast International Group, which is 60 groups in 5 continents, to look at barriers and facilitate sustainability integration. And what we found was that the challenges to engagement were time, resource constraints, apathy, and financial complaints. And if we move the dial to facilitate us to engagement, things like funding, things like evidence-based guidance documents and training, we're going to move the dial in the area. So moving the dial in the area also involves alignment. You have to align organizations. So this is an example of alignment. So this is a massive attack, did a concert in Bristol, 30,000 people turned up. And they partnered with the Tyndall Centre and the University of Manchester. And the goal was to reduce the carbon footprint of the concert by 98%. And what you can see here is that they got it in terms of electricity reduction and travel, the kind of things you think about. But the biggest move to dial here was food. Because if you had a vegan diet, your carbon footprint was dramatically different to if you had a vegetarian diet or a chicken or a poultry, whatever diet. And That's reflected in this slide on the right-hand side from Our World in Data, where 80 billion animals are slaughtered every year to sustain us. And changing the diet, moving the dial in terms of diet is very difficult. I had a chicken sandwich at dinner today, and which shows how difficult. And I knew I was going to be talking here today, so I decided to confess early. But these things down here, these studies down here, My Planet Diet from Dublin, the FEAST program, which is a wonderful name for a trial, and a food labels trial, look at how we can use using randomized clinical trials to see how we can do behavior change, which will ultimately have a climate change ability. The second thing is, the other lesson we learned is the role of advocacy. You can't move the dial without funds, but if our politicians aren't aware that this is an issue, they won't be brave in terms of making awareness of funds. A lot of us are down here at the pure scientist level, where is very little policy influence, and we need to move into a zone of uncomfortableness as an issue advocate to be advocates, because we need to go to this on the right-hand side, a climate resilient, low carbon healthcare system, which also requires leadership in order to implement it, and funding. We learned that climate change causes profound human suffering. So this is from a webinar that we did in conjunction with the Latin American Cooperative Oncology Group and the Society of Latin America and Caribbean Oncology in November of last year. And testimonies from Porto Alegre in Brazil outlined an enormous flood. So basically the floodplain is D and the normal is C. And an area half the size of London flooded because of a constellation of environmental factors here. And this devastated, we had testimonies at the webinar from oncologists who couldn't practice because all of the infrastructure had gone. And you could say that that's very, that's an inconvenient reality, but it's not, it's an inevitable reality, because the rainfall in this area is going to increase by 86% over the next 80 years. So this is going to be their new reality. In Bangkok, 40% of Bangkok will be underwater by 2030. So how do we pull these things together and go home with a message about what can I do in the clinic tomorrow morning? So this is an example. So the first thing is alignment. We need to align our research labs, our trial design, our funding bodies and ethics to look at mandatory carbon impact involvement and mandatory funding that will come as part of that. We need to look at trial delivery and procurement in what we do. And we need to get licensing bodies introducing carbon limits on interventions. If I asked any of you how you deal with this problem, you would say, I would measure the problem, I would assemble a multidisciplinary team, and I would build a network. So this is your network here, the MRC NIHR TMRP group, led by Lisa Fox. And the bottom one then is a climate chart of your Cancer Clinical Trials organization, everything from what to order at a meal to pension plans for your employees. I'd like to finish by acknowledging the many trainees that have been involved in these papers on my network. I'm also a Gold graduate, and I would like to acknowledge Professor Turlock Fitzgerald. He and his wife Maeve ran the Department of Anatomy in UCG, and his daughter now works with us. Una works with us on our climate change initiatives. He was my first mentor. He had a profound impact on my life, and it's lovely to be in Galway to acknowledge that. And this is my final slide. Thank you very much for listening to me today.
Thank you very much, Seamus and Professor O'Reilly, for bringing, yet another profoundly important topic to the discussions today, and really a topic that needs to be in every room and every discussion. Our next speaker is Professor Ellen Roach from the Massachusetts Institute of Technology. Professor Roach's research is focused on device-enabled approaches to assist or augment dynamic tissue, primarily the heart, through active assistance and delivery of biological therapy. Today, Professor Roach will outline her lab's approach to accelerating progress along the translational path to clinical trials. Thanks, Professor.
Thank you. Thanks for the introduction and the invitation to be here. It's been a great day so far. So I'm an engineer. I'm going to talk about device development, especially in the cardiovascular area. Okay, so this is the total product life cycle for medical devices, and you can see it's a roller coaster, as many of us know. I'm interested in this loop where we optimize the design, we do non-clinical testing, animal studies, and early human studies. This all happens before design freeze and before a regulatory decision is made. So I'm going to talk about some examples that we've done in these areas. We want to make it more efficient, but of course safe. So in silico projects, we do a lot of work in the in silico space. These are digital or virtual trials. And regulatory bodies, including the FDA, have advised that modeling and simulation can be used to predict clinical outcomes, to inform clinical trial designs, to support evidence of efficacy, to identify which patients to study, and to predict product safety. But of course, these require more verification and validation. There's a very interesting paper towards trustworthy medical device in silico trials. It talks about the clinician and the virtual cohort of patients providing initial boundary conditions that feed into models of the device, the patient, and then the device plus the patient together. With acute physics-based predictions, we can predict safety and effective clinical outcomes and endpoints. Of course, we need to be very conscious of the decision consequence and the model influence and how we can model risk of using these trials. In my group, we were interested in building patient-specific models of the heart. If a patient could come in for an MRI scan, could we very quickly have a virtual model of that patient's heart, not only the physics, the hemodynamics, the cardiac biomechanics, but even the tissue of the heart? This is possible, but traditionally has been quite slow. So we worked on a data-driven surrogate using machine learning techniques to go from MRI scan to a virtual model in less than a second. We had to do 3 main steps to make this work. First, we developed an automated tool for consistent meshing of the left ventricle. We built a large simulation data set using finite element models. And then we created a principal component analysis transformer model, which would predict the dynamics of the left ventricle 10 to the 4 times faster than traditional finite element models. So just to go into some specifics, I won't go too deep on these, but this is the workflow for automated left ventricle meshing. We have a scan here. In this case, it's a cardiac MRI scan, multiple slices. We do some smoothing processes and surface projection to create a patient-specific mesh of the left ventricle. We did this for hundreds of ventricles, and then we created these finite element models with the mesh in this lumped parameter reduced order model where we can input values for the resistances of the valves, the aortic and mitral valve, the overall systemic resistance and compliance. What we end up with is this beating heart model. It's not only just a moving heart, it can predict pressures and volumes, and you can get a pressure volume loop for 4 cardiac cycles. When I say we, my student did 536 simulations, each about 14 hours worth of simulation for 270 different left ventricle shapes. So you can see a number of these, and they matched very closely to the cardiac MRI data. Now we wanted to do this so we could make it very usable. So we used an autoregressive transformer model. This is a model similar to large language models like ChatGPT. We input our finite element model, our shape principal component analysis, and then sequentially the displacement, so from frame to frame. And now we can have a movement sequence of any length. When we use this data to train a surrogate model, we can come up with a transformer model that matches the finite element model very closely. And this was the case for the vast majority of those that we trained. And of course, it does it instead of doing 6 hours on a 16-core CPU, we can do it in half a second, and we can do 100 cases in about 0.1 of a second. The pressure volume loop matches very well. The orange there is a finite element model, and the blue is a surrogate. We can also do this for mitral valve dynamics. We partnered with Dassault Systems and the Living Heart Project. Here we used a graph neural network model, and we can predict the stress and the movement of the mitral valve leaflets. Again, similar story with aortic stenosis. This is where the aortic valve becomes narrowed and calcified, and we really wanted to get an imaging data set and predict or categorize the severity of aortic stenosis very quickly. Instead of the traditional approach, which takes hours where someone does slice-by-slice segmentation, we came up with a methodology called DeepCarve with partners at Yale University, where we could go from a pre-op CT to a simulation-ready mesh on the order of seconds. So this is the 4D cardiac CT, and here is our DeepCarve method, where we can mesh the ventricle, the aorta, and the aortic valve in a short amount of time. We can also look at calcification on the aortic valve, and we mesh this differently and apply different properties. So you can create this virtual twin where you do fluid structure interaction and you can predict the blood flow through that valve on a patient-specific level. So this shows the velocity streamlines of the patient's blood moving through their calcified valve. And we have this mesh, so we can also use 3D printing techniques to create a benchtop twin where we can study this on the bench and try out different technologies to repair or replace the aortic valve. This is a powerful tool. As you can see, this is a whole heart model. The leaflets are moving and you can assess hemodynamics very well. Really helps with accurate classification of degree of aortic stenosis. We did this for a number of patients. There are 5 shown here. Instead of the conventional method where the calcification is just part of the leaflet, we actually have 3D calcifications, and these lead to more accurate computational models. Here, the velocity across the valve for these 5 different patients is shown, and you can see how it varies significantly from patient to patient. So with this method, we were able to come up with a new methodology, very quick way to go to a simulation-ready mesh. The ground truth in the graph on the right is the echo data, which is shown in dark gray. Our method is in light gray, and the conventional method is in orange. And this is for pressure gradient, max pressure gradient. And you can see for these 5 patients shown here that the method is actually more accurate or closer to ground truth than the conventional method. Now, I'm a big believer in spending more time testing on the bench before moving to animal models and accelerating preclinical pathways with in vitro models. This is a big focus of my lab, but I won't show too many of these models here in the interest of time. But we build biorobotic models where we use explanted tissue and we reanimate them with robotic structures to make them beat again on the bench. We instrument these models heavily so we can measure pressures and flows, and we can recreate very accurate physiological pressures in the ventricle, the aorta, and the atrium. We can also measure flows across the aortic valve, across the mitral valve. And the really nice thing about this for accelerating device development is that you can see inside these tissue models. So here we can see, visualize with an endoscope the aortic valve opening and closing, a real tissue valve. And on the right, we show ultrasound. We can do the same for the mitral valve. You can see the functioning of the mitral valve directly and with ultrasound. And we can use these for device testing. Just in this one case that I show here, we look at the MitraClip, a device developed by Abbott to clip the mitral leaflets together and prevent regurgitation. And you can see visually the effect of that clip inside the heart model. This is impossible during animal studies or in patient studies because it's all done minimally invasively. The blood is in the way and you're just looking at a 2D X-ray instead of this visualization. Nice for a training tool and for rapid device iteration. Okay, in the last 6 minutes, I'm going to talk about some early clinical investigations, as Professor Melvin mentioned earlier. These are devices that we've developed in the lab that or clinical trials that we're doing, but they're very early stage. The first is a novel device for obstructive sleep apnea. Sleep apnea is common, it's underdiagnosed, it's associated with increased risk of hypertension, heart attack, stroke, premature death, neurocognitive effects, accelerated progression of Alzheimer's. It disproportionately affects people with Down syndrome, and I'm really interested in working with the Institute for Clinical Trials to do some more studies in this population. Our device works by stabilizing the tongue against the hard palate with an aligner that's just like Invisalign. It has a low level of suction to keep the tongue muscle in place during the sleep and prevent the posterior movement of the soft tissue, which blocks the airway. We did some MRI studies with this device in patients, and we showed in a healthy control and in a person with obstructive sleep apnea that we can actually increase the size of the airway. These segmented 3D images show the airway size. So by stabilizing the tongue, you can increase that airway size. It's a fully digital 3D workflow. On the initial visit, we consent the patient, we do an intraoral scan with a camera, and we can reconstruct the anatomy of the teeth and the hard palate as shown in the video here. Then we do design in CAD software. We have a machine learning algorithm as well to make this patient-specific design. And we manufacture by 3D printing in dental resin that's approved for intraoral use. In the end, we want to have a device that looks similar to the image shown on the bottom, where the pump is miniaturized and no bigger than the size of the phone. We have done some initial studies at MIT where we've looked at healthy volunteers who confirmed the comfort of the device. We did this in 30 people. The tongue is stabilized very well. We also did some trials on patients with obstructive sleep apnea, and we measured what's called their AHI, their apneic-hypopneic index, which is the number of events per hour of when they stop breathing. This is one representative patient without the device. They have an AHI of 10.7, which means that they have a suspected pathological breathing disorder. And then with the device, their AHI is in the normal range. This is positive and encouraging, and studies are continuing. The final study I'll mention is more on the fundamental side. We want to understand cardiorespiratory interactions in congenital heart disease. We're interested in single ventricle physiology, and this work is done in collaboration with Boston Children's Hospital. This is where patients are born with one pumping ventricle instead of two. Because of this, there's interactions between their pumping and between their heartbeat and their breathing. When they breathe in, the thoracic pressure drops and blood is brought to their lungs. When they breathe out, it goes the opposite way. And blood on their venous side can actually go to the liver and lead to liver disease. This kind of reversal of flow can lead to liver disease, and we're interested in studying these mechanics to really understand why this liver disease will happen. So we set up a study where we look at MRI and echo imaging of patients that have single ventricle physiology, and we measure this reverse flow at rest and during exercise. So after consenting, we do MRI imaging. The patient goes in the MRI machine, they do a breathing exercise, and they exercise with an ergometer that we custom made to fit in the MRI machine. And then we repeat this with ultrasound because that will allow us to do imaging in a lot of different positions ultimately. So for the MRI study, we have a respiratory protocol. They look at an audiovisual guide like this, the meditation app, which helps them to breathe in a very specific way. And then we have them exercise in the machine. We image 2 millimeters above the hepatic vein, and we can look at the MRI and measure the flow in the IVC in the hepatic portal vein. We did this on 30 patients. When they increased their respiratory effort from shallow to deep, but maintained their respiratory rate, we could see an increase in the amount of reverse flow. When they increased their respiratory rate from slow to fast breathing, but maintained the effort the same, we also saw an increase in the reverse flow to the liver. And these insights hadn't been described before, so this is really interesting to the surgical team that we work with. When they exercise in the scanner, they do level 1, 2, and 3 of exercise. Their heart rate goes up, the flow in the inferior vena cava goes up, and the reverse flow actually goes down. And this is shown by these traces that we can measure in the scanner. Again, this is interesting to inform non-invasive interventions and potentially device design in the future. We then moved to an echo imaging study because if we can do this with ultrasound, we can do it when a patient is standing up or doing different types of exercise. The protocol was the same, except we were using ultrasound to measure flow. We saw very similar results. Here you see Doppler ultrasound in shallow, deep, slow, and fast breathing, where reverse flow is shown in red here. And then we came up with an algorithm to track the flow in the IVC and in the hepatic vein while the patient is breathing in the different breathing exercises and the exercise protocols. And you can see how it synchronizes with respiration and how in the expiration period, you can see a period of reverse flow. This provides a better diagnostic tool for screening congenital heart disease patients that are at risk for liver disease, and it informs development of devices. Hopefully, it enables clinicians to perform non-invasive imaging in the future to monitor progress and predict somebody that's at risk. My time is up, but I want to finish just with this maybe slide, which I put together with an industry colleague of mine, and lots of this has been talked about today. I think there's traditional prospective clinical trials. There's real-world evidence, and that's becoming really important now. decentralized clinical trials have been talked about a lot today. And then I mentioned our work and a lot of the work going on in silico model and virtual patient modeling, which I think will be a big part of our future. So thank you for your time. These are the group that did all the work. I'm very grateful for.
Thank you so much, Ellen, for that fascinating talk. I'm now delighted to introduce Despina Vulgaraki, who's the Senior Director of Clinical Research and Medical Science for Western Europe Enterprise Accounts at Medtronic. With over 2 decades in preclinical and clinical research, medical affairs, and medical education, Despina's work spans academia and the medtech industry, focusing on cardiovascular, neurological, and autoimmune diseases, with extensive R&D work on hepatology and oncology also. So Despina, I'll invite you to address us.
So much. It's really a pleasure to be here today. Thank you so much to the organizers. So I was tasked today to give you a little bit of overview of how we're thinking about emerging trends in clinical trials from the point of view of a medical device manufacturer. So I'm gonna go through a few examples, and Professor O'Reilly actually really set up the scene very well. I'm gonna talk about decentralized trials and in silicon designs, as well as how we look at patient centricity and diversity in clinical trials, which is something new for us, but it's really the right time and the right thing to do right now. And finally, I really want to kind of close with an emphasis on how we're thinking about collaborative approach and partnership as well, because clinical trials shouldn't happen in silos. And this is where we fail, when we only look at it from one point of view or only as an industry manufacturer without really expanding the scope. So look at the current landscape. Let's take a step back and look at clinical trials. And right now, we're living in a very, very complex world. So what you see is a very evolving regulatory landscape, right? So you have stricter compliance and more comprehensive documentation required by regulatory authorities. You have lack of harmonization, or in Europe we will call it decentralization, but also clinical trials don't really happen necessarily in one country or in one region. So as a manufacturer, when we design clinical trials, we would be designing them perhaps as a global protocol. So then how do you harmonize between what the FDA asks for you, what the decentralized regulatory system asks for you here in Europe, and what Japan or Australia, New Zealand may be asking from you? And then there is increased protocol complexity, which actually gives rise to an increased cost for the conduct of clinical trials. And there's some data in there, it's really rising up exponentially. And then there is exponential and emerging technologies. We've been talking about this throughout the day, right? So you have new data sources, you have real world data, they present an opportunity, but then how do you actually approach them? How do you incorporate them within your clinical trial design? Then you have new methodologies, you have new data management systems, you have wearables, you have patient applications, you have omics, right? Professor Sirois actually talked about something that I didn't know, organomics, for example. It's a very new term for me. You have complex diagnostic and therapeutic modalities, and they all go within the same clinical trial design. And then you have artificial intelligence and machine learning. And again, that presents an opportunity. We heard some wonderful examples from a clinical development perspective from Professor O'Reilly, but then also has some challenges that comes with it. There's societal shifts, right? Again, clinical trials have to happen in context. We're more and more aware about the need to include the patient voice in the clinical trial, and just not include the patient voice. I think Chopin said it really well. The patient needs to be in the room and it needs to be listened to. You have also patient and people-centered care. You have citizen-led and deliberative approaches that you also need to take into account. And finally, transparency, especially as an industry and as a manufacturer, we have an obligation to be transparent about not only where we succeed, but also where we fail. And Marianne Wanden, my colleague, this morning, she gave you a fantastic example of how we failed and learned from that failure as part of the renal denervation therapy development process. And then there is health systems under pressure. So my home country is Greece. We invented the word crisis, right? And then actually live in London, the UK. And if any of you has actually seen the news over the last few years, NHS in crisis, NHS in crisis, NHS in crisis. nobody can fix the NHS. So I'm just quoting The Guardian, right? That means there's a need for rational and optimal resource allocation, right? But then we have to make those decisions. How do you reward innovation? How do you get new technologies, new therapies, new medicinal products on the market, bringing them to the patients faster, cheaper, more efficiently, but also balance cross-sector priorities? Do you invest there or do you invest somewhere else, right? And we have to think of clinical trials as part of that ecosystem. I'm not here to tell you how we will do it, but I'll give you a little bit of a glimpse of how we'll apply some of that, how we're thinking about it at Medtronic and how we're approaching some of those aspects. So this is just indicative. As preparation of my talk, I started kind of like, doing a PubMed search basically, and there is so much out there about what the future of clinical trials could look like. We spent the whole day discussing this, right? And that's just not beyond academia or beyond basically the work that you see there. There is also a lot of work by CROs, by NGOs, by charities. I want to think about four things today, and I want to speak about four things today. I want to talk to you about trials that are patient-centric, about trials that are decentralized, and Professor Riley actually really set up scene really, really well for me. I want to talk about how AI, digital, and data-driven trials are becoming the norm today. And also, I want to talk about partnerships, because again, trials shouldn't happen in silos. So, patient-centric trials. Essentially, patient-centric trials really prioritize the patient's needs, their preferences, their well-being throughout the entire process, not just like in one aspect, but ideally, you have it from beginning to end. And their whole idea is that it leads into trials that would be more flexible, right? More supportive, more engaging for participants, ultimately leading to being more effective and relative therapies. Why are we doing trials? Because we want to give patients more choice when it comes to their treatment. Why shouldn't we include the patients as part of the process? It's new, isn't it? Like we didn't think about that 10 years ago. We didn't think about that maybe 5 years ago, at least as industry. And then you have many ways that you can think about how you will include the patient's voice. And as part of clinical trials, you have decentralized trials, you have hybrid trials, you have community trials. So Dr. Sandra Gandhi actually talked to us a little bit about community trials earlier this morning, especially in the cardiovascular space. You have incorporation of digital tools, of wearables, of patient apps that allow the patient to directly input their data, so not through their healthcare provider, into the trial. You have appropriate engagement of patients in clinical trials. And you can also then address diversity and inclusion. You're including patients. Are you including the right patients? Which patients should you include? And then, of course, sustainable trials. What I learned today, and I never really thought about that, the cloud actually is not very climate friendly, is it? So when we're talking about the opportunity from a data perspective and from an AI perspective, just thinking of all the servers and the computing power that comes with that. So that's not really green, is it? And I never really thought about that. I'm ashamed to say. So this is an example of how we're thinking about patient centricity in clinical trials and Medtronic. We're thinking that it should be an engagement and empowerment of patients from beginning to end. So we took all the phases of a clinical study and we mapped out and saying, well, where does the patient fit in? Where should they have a say? And actually, they have a say everywhere. Let me give you an example. The second green arrow, ICF development, informed consent form. I spent maybe 15, 20 years of my life designing clinical trials or conducting, executing clinical trials. Have you guys seen an informed consent form? Who has seen one? How many pages is it? For medical devices, it can be a little bit less if you're fortunate. It can be 15 to 20. Who's going to read 20 pages? Yeah. What kind of language is it written in? Is it easy to read? Would my 80-year-old grandmother be able to understand it? Why don't we put it in front of a patient and tell us what they would like to read and what information they would like to receive? Have you seen brochures about that we may give out in a clinic to patients so they can think about participating in a trial? They usually have a nice cover, they have a nice patient, maybe. What does the patient look like? They're a man, they're white, and they're 80 years old or 60 years old. They don't look like me, or they don't look like many of you out there. And these are things that we never really thought about until recently. So that's part of the society shift, right? Okay. So, and then also the time under which the consent is sought is very stressful. It's a very stressful process for patients. Myself, when I go and have a regular checkup, I might be asked, oh, do you want to participate in this trial? And then, although I do trials every day, that's my day job, I find myself really stressed when I was asked recently, don't want to blow into a tube, basically, because we're looking at biomarkers for X. Let me give you an example of how we're thinking about patient engagement in clinical trials as part of the design process. So this is with heart failure patients that have preserved ejection fracture, basically. And we were designing the protocol, and we thought for the first time, actually, we should ask patients, because we know there's a lot of issues with trial recruitment as well as patient retention in clinical trials. And so we did a 6-week sprint, basically, to identify 10 patients and really have 60 minutes structured interview with them and collect qualitative data about what matters to them and why would they consider actually being part of a clinical trial. And we actually incorporated what they suggested as part of the protocol that helped us, a manufacturer, to attract patients fast, meet our enrollment timelines, ensure that patients were retained within the study. So these are all important qualitative criteria. But we also learned something. Heart failure, actually, let me take a step back. If you think about clinical trials and think of endpoints, what do we measure in clinical trial? A lot of them can be highly technical. And we find out that patients don't really care about technical endpoints. They don't really care about composite endpoints. What they do care about is their quality of life. Will I be able to exercise again? Will I be able to have my legs, they won't be swollen anymore, basically. I'll be able to run after my grandchildren or my children. And this matters to patients a lot. Regulators care about technical endpoints. We as an industry take about clinical endpoints because we want to maintain that scientific integrity and validity. But patients may not care about a composite endpoint that has 5 different technical variables in there. And then diversity and inclusion. So think about diversity and inclusion. Are we actually representing the right patients as part of our clinical trial? No, not. This is US data. 58% of the US population is women, but only 41% of women are included in US clinical trials. Let's talk about cardiovascular trials, the bread and butter of Medtronic. What is the representation of women in cardiovascular trials? Anyone knows? Professor Sirois, I'm going to call you to it. About 25 to 30%, right? You're absolutely right, sir. What is the representation of women in the society? Don't have a 75% men, 25% women, right? Okay. And for the purpose of this talk, I'm not going to go into gender and all that, basically. So how we should be thinking about that, really? Are we really including a representative patient population? I'm talking about gender, but there is also race. There's many other aspects that, again, as part of how we're thinking of our society, should be incorporated into our clinical trials. We have a vision, Medtronic, that clinical trial participation should be representative. And we're designing an entire ecosystem to ensure that, again, we have a representative patient population. Things could include, for example, an enrollment goal definition. We usually look at clinical trial design and we say we need X number of patients to be able to meet our hypothesis, basically, and prove that the device or the therapy or the treatment is superior or not inferior or whatever. But here we're looking at how many women you need to have or how many African Americans, if you're doing a study in the US, you should have. That is actually very much aligned with the incidence and the prevalence of the disease in those patient populations. Let me give you a very recent example as well. This is the SMART trial. And actually, Dr. Sandra Grandi talked about it this morning. She said about how basically cardiovascular disease presents differently in women, how many times, and it's usually confused with what perimenopause and menopause symptoms, actually. So basically, we know now, we didn't know until recently that aortic stenosis impacts women differently than men. So the SMART trial was designed to look at patients with small aortic annuli, basically. So that is mostly women. And we enrolled not 30% or 25%, as Professor Siroi said. 87% of the population were women. And to me, that is like a pivotal moment of how we think about clinical trials, because we're looking how that therapy actually behaves, not in a general patient population, but specifically in women as well. And then there is something else, for example. Another example is our next generation pulse oximetry technology. So here, one of the challenges we had is slow recruitment of darkly pigmented participants in US physiology. Why? Because when we actually develop a technology, when we think about a technology, it's the first thing that you think about, oh, patient, white, male patient, basically. And the technology may not necessarily reach the patients that are of different race or different color, basically. So from a tactical perspective, again, we included patients as we were thinking about how we want to execute the study. And we asked them. So one of the things that we did is presentations in churches and historically Black colleges in the US. Again, community-based approach. And it was wonderful to hear from Sandra Grady this morning, how she is also thinking about that in terms of cardiovascular drugs. Decentralized, hybrid, and community-based trials. This is essentially what we are discussing right now. We're discussing about, and that really didn't happen before COVID. It was COVID that really was the watershed moment. The tip of the evidence-based pyramid is just beneath systematic reviews, these randomized control trials. They give sponsor the control that we're looking at. They're very highly rigored. I would call them stiff almost, basically, because you want to be able to control every single parameter, including how you include patients. But when it comes to decentralized trials, you're going to look at different aspects every step of the way. So recruitment, use digital platforms. You don't expect the patient to come into the clinic. You're going to go to where the patient is actually. You're going to look at randomized group assignments that can be done digitally. I still grew up in the era of, open up an envelope, or in a cat lab. You're going to look at informed consent that utilizes electronic documents. You're going to look at interventions. This specifically applies to medicinal products, basically, where interventions can be remotely administered. You don't actually have to travel to the clinic. Doesn't apply so much with implantable devices. And then monitoring utilizes wearable devices and patient apps as well. And you see an explosion when it comes to the type of thinking and applications in trials altogether. And you can see in the most recent update for ICH GCP, Annex 2 is currently under review. This is the first time where we see, from a regulatory perspective, or from a guidance perspective, sorry, a focus on decentralized trials and community engagement as well, as part of guidance documents for good clinical practice. I'm looking at the time, so I'm so horribly going to be late. There are opportunities and challenges for decentralized trials. Let me just talk a little bit about challenges. It's not as peachy as it sounds. You have usability and practicability of the technology, digital literacy. If I'm going to ask my 85-year-old grandmother to use a patient app to enter her symptoms, she'll be like, what? So can you come over and do it for me? Basically, she'll tell me. And then she'll ask me, oh, what do you think? What do we, yeah. So then you also have to think about paradigm shift and trial data quality. Again, it's the mentality of moving from the very rigid, rigorous structure of randomized controlled trials to letting go a little bit, and then at the cost of potential quality. And then ethics and regulations. There are regulatory documents out there, the EMA, the FDA. You have health authorities. Actually, in Europe, it was the Danish health authority that came up in 2021 with guidance most recently. So our decentralized trial is going to be accepted by ethics committees and regulatory authorities. Real-world evidence, I'm not going to touch too much into it, but at Medtronic, we look at real-world evidence across the entire clinical development life cycle. This is an example where for our Micra, or miniaturized pacemaker, we use real-world evidence to obtain coverage, so with evidence development. So the technology was able to reach patients earlier, but we use real-world data to ensure that we had the sufficient evidence basis to continue asking for reimbursement. Digitalization and AI, artificial intelligence in clinical trials, huge opportunity. We have a massive transformation of data analysis in clinical trials. Professor Riley talked a little bit about, sorry, I'm going to skip that. Virtual trials, in silico trials, digital twins. They don't only apply in terms of product development, they also apply how we're actually designing clinical trials. They can actually reduce the time that it takes to conduct a clinical trial. They can reduce the number of patients that you will need as part of your sample size. So to give you an example here, our leader study, we used virtual patients. So we did digital twins essentially and in silico simulations to be able to reduce the sample size that we needed to conduct the trial. That means we're able to execute the trial in a shorter amount of time. We were able to get all regulators aligned as well. Think of the evidence-based pyramid. We know about that really top segment. There's an iceberg, actually. There's an evidence-based iceberg. Because all of the things that we talked about have to be actually collectively thought about when it comes to development of new products and therapies. And that is the challenge that we are facing. I want to close very, very quickly with collaborative approaches and partnerships, because again, clinical trials shouldn't happen in silos. And especially the relationship we have with academia. Professor Max Palmer actually talked about it, that it's really, you build it from an academic perspective, we will come as an industry, because we still think about trials as point of intervention for one specific indication and condition. We haven't really evolved our thinking into the paradigm shift of thinking about multimorbidities or thinking about embedding trials as part of the healthcare process and treatment pathway. But we are very privileged to be working with the University of Galway, both on the HUEFS project, Tom Melvin talked about it in the morning, as well as a brand new project called GREG, which is looking at basically co-creating guidelines for real-world evidence generation in Europe, both for regulatory access and health technology assessment, as well as we are participating with Galway on Marie Slaughter-Curie actions, and hope to tell you a little bit more about that because it is specifically on diversity in clinical trials. So let me just close by basically telling you that this is a new era. This is a brand new world. We have emerging technologies and trends. They're revolutionizing clinical trials. They're enhancing data collection. There was a very, very important note from Mary Horgan this morning, and we didn't touch upon it at all, because clinical trials also have to be in the context of increasing preparedness and resilience. COVID taught us that painful lesson. The patient-centric approach is the one that matters. The patient needs to be in the room and it needs to be listened. And then finally, that collaborative partnership we have with academia, as well as with small, medium enterprises, that innovation ecosystem in Europe with European funding mechanisms can make the whole difference. That was fast.
Thank you. Thank you so much, Despina. What we're going to do, I think, is we're going to hold questions until the end. So we'll have the time for all of the speakers in the session. So if you can be thinking about your questions. But I think, Despina, your talk has teed us up really nicely for our next speaker, who is Professor Noel O'Connor. Noel is the CEO of the Insight Research Ireland Centre for Data Analytics. And I think what we've seen, collaborative efforts between data analytics, AI, and machine learning experts have been and continue to be crucial to the future of clinical research and the advancement of medical science. Insight's researchers are based across 4 host institutions, one of them which is here in the University of Galway. Welcome, Noel.
Great, thank you very much, Ruth. As Ruth says, my name is Noel O'Connor. I'm delighted to be here. Thank you very much, Fidelma and team, for the invitation. I'll go further and say I'm actually honoured to be here, given the calibre of speaker that you've had on today and the inspirational nature of some of the talks that we've heard, which has given rise to massive imposter syndrome on my part, because I'm probably the least qualified person in the room to talk about clinical trials. But what in discussions with Elaine and with Fidelma, what we thought I'd do today was give you a snapshot and an overview of the Insight Centre. It's been mentioned a couple of times today, and I find as I go around the country that sometimes people have one view of Insight because they've interacted with us through one particular lens. What I thought I'd try and do today was give you the bird's eye view of who we are, what we are, the scale of our operation, with the key takeaway message being that in effect we are a platform for collaboration. for collaboration nationally. And we are really, really, really keen to understand how we can collaborate with the community represented in this room and play our role in the transformation of the future of clinical trials. Professor Sharif and Professor Horgan this morning spoke about the importance of a national perspective. And that resonated very strongly with me because actually it goes back to the genesis and the establishment of Insight. Insight was established in 2013 when it was recognized that within Ireland we had pockets of excellent expertise in all aspects of data science, from data analytics, machine learning, data engineering, and what's now being referred to as artificial intelligence. But it was also recognized that this led to a very fragmented ecosystem that was difficult to navigate for whoever needed to navigate it, whether they be industry partners, large or small, the government, or indeed the public. So the decision was made to bring all of those pockets of expertise together into one umbrella, which became Insight, and establish a genuine national research centre. That is reflected, as Ruth has said, in a unusual, we believe, a unique model. We haven't found one elsewhere like it in the world, of a research centre which is genuinely co-led by multiple institutions. In this case, in Ireland, University of Galway in the west, University College Cork in the south, University College Dublin, and Dublin City University in the east. And then other universities in Ireland can participate in the centre through those co-lead partners, to the point whereby, as of today, I'm proud to say that we have every university in Ireland, including all the new technological universities, the Tyndall National Institute and the Dock Institute of Technology, collaborating with the centre in some way. We were set up with a significant investment and sustained investment from Research Ireland to act as an engine of innovation for industry. That's enabled us to partner with over 170 different industry partnership projects. And we've been very successful because of our national reach and scale in diversifying that original funding base via other awards, either national awards and, really importantly, international awards, non-exchequer awards from the likes of the European Commission. We're also mandated to nurture the next generation of high-tech Irish entrepreneur, and that's reflected in the fact that we've had 16 spin-out companies. We also, of course, produce talent as a byproduct of what we've done, and over the course of our existence, over the last 11 years, we've graduated over 390 PhD students. We are inherently interdisciplinary and multidisciplinary. We bring together principal investigators from right across the ecosystem. There is a concentration in areas like computer science, engineering, and applied maths and stats. But over the last 5 years in particular, we've reached out to other disciplines, recognizing the importance of getting that transdisciplinary approach to research if we really want to produce genuine impact from our research. So we have experts from schools of English, drama and film, health and human performance, history and philosophy, information and communication, medicine, anesthesiology, and so on. And the list goes on, and this is only a sample. So in effect, the way I encourage people to think about Insight is an expertise base that pulls together from all corners of Irish academia, and an expertise base that can be mobilized agilely to respond to societal challenges. And the best example we have of that is the role in which we played in the national response to the COVID pandemic. So as soon as COVID hit, IMAG was formed, the Irish Epidemiological Modelling Advisory Group. A number of my top investigators, top professors, down tools on their day job, joined IMAG and worked tirelessly to produce those SEIR models and the reproduction rate that we heard about every evening on the news via IMAG, by the IMAG chair, Professor Philip Nolan, or the CMO himself. That was spearheaded, by the way, by people of this parish, like Jim Duggan and Moira Connolly, for example. But we didn't just stop there with the disease modelling. We also worked with Research Ireland to establish a national working group, a scientific advisory group, on helping the HSE with the development and rollout of the National COVID Tracker app, which was considered to be a huge success with 1.44 million downloads, and is considered a model of internationally as a model of best practice, right? Because the source code was open source, it was distributed, and it was used in other jurisdictions. We also worked closely with the Irish public. Again, through researchers in the University of Galway, like Mark Malott, Eki Veligner, and Galina Brishkova, who actually worked with the public to try to understand what the public attitudes were towards restrictions or easing of restrictions, and then communicating these back to the general public via the main evening news, for example. It's all based upon scientific excellence. I won't belabor the point, but we exist and we are successful because we have a foundation in excellent science, as evidenced by the various journals in which we publish. In the area of AI and machine learning, conferences are increasingly important because they can't keep up. The journals can't keep up with the conferences, and it also gives us an opportunity to send our brightest and best around the world to evangelize for Ireland as a good place to do AI-related research with real impact. And we have the stats to back up the quality of our research, which is really, really important, because at the end of the day, there's significant investment from the Irish taxpayer into our science. The other thing our scale and breadth allows us to do is to bring together the top leadership across the country. These are just three of our top senior leaders, and you recognize some of these people. So Barry O'Sullivan, for example, I think is still the chair of NREC MD. Brendan Murphy was a key member of IMAG, as I've mentioned. But importantly, this framework also allows us to bring through the next generation of leaders. So whether that's, for example, Paul Bannahan there, who's a late-stage PhD student in Insight and is recently appointed as an AI research fellow at the Mater Hospital, the first such appointment, we believe, in Ireland, or taking a role in ensuring that gender balance is a key aspect of the future of AI. We've huge diversity and gender issues in our discipline that we need to address on an ongoing basis. So we're very proud that Begum there is the Irish ambassador to the Global Women in AI organization. And we're very proud of the fact that over the last 2 years, we've had 2 ladies in the top 30, under 30, as recognized by the Sunday Business Post. Our scale also allows us to assume national leadership positions. So we co-lead 4 of the 5 centres for research training, that are funded by Research Ireland, that will collectively produce over 700 industry-ready graduates by 2027. And we also key lead the European Digital Innovation Hubs, one of which, for example, is led out of Galway here with ATU and University of Galway Data to Sustain. We're also very industry focused, so we can work with companies both large and small in any ecosystem. And we can tailor our modes of interaction and partnership to the company's needs, whether they be short-term, small projects, or longer-term, much larger projects. And we're also capable of taking an international leading position to help influence the international agenda in data science, all things data and AI. So whether that be, for example, being members of the Global Partnership on AI, membership of the European Innovation Council. We were co-founders of the Big Data Value Association and ADRA, the AI Data Robotics Association, courtesy of Professor Ed Curry, who's sitting in the audience there, who's our Insight Director in Galway. And of course, the payback from an Irish Inc. perspective of that leadership is we maximise our take in terms of EU funding. Our success rate as a centre in terms of securing funding from Europe is of the order of 25%, where most Irish institutions would be happy to be in the 15, 16% type of category. So we're big, we're here, we're good value for the taxpayer, and we're a going proposition. But beyond that vanity slide is the fact that I come back to the fact that we are a national collaboration platform that's open for business. We want to work with Ireland and Ireland Inc. and communities like yourself to help to understand how Ireland can leverage the digital transformation and AI dividend in impactful ways. And my goodness, talk about the impact we've seen this morning and this afternoon, a potential impact we've seen in the earlier talks in this future-looking session. So I suppose that's my key takeaway message, is that we are here. We're open to collaboration. We're keen to collaboration. So we're really looking forward to working with this community. I'll conclude with a short example of what that might look like in practice, taking a project from the University of Galway. So we've seen multiple times in multiple talks now the potential opportunities offered by AI, notwithstanding the challenge that AI brings in terms of climate change and the environmental footprint, which I won't get into now. But interestingly, there's a parallel there with my community. We need to change the way in which we do our own research. But the program I'm going to show you now is about how we've been able to open up access to compute and data storage in this scientific discipline, AI, which is increasingly becoming more and more closed thanks to the big multinational players who are driving the agenda here. And how we did so through the medium of open science, which is something else we are required to work under and adopt as our operating ethos. So in this project, I'm going to give you a short overview video of now. We were successful in securing over 650,000 euros worth of compute and data credits on the open cloud research environment under the European Open Science Cloud Programme. And it enabled us to do something I think is very impressive with colleagues here in the University of Galway.
The aorta is the main blood vessel that leaves the heart, and it works in conjunction with the heart to distribute blood around the body. 150 to 200,000 people die each year from aortic disease, which is more than breast cancer, pancreatic cancer, bowel cancer. We look only at the aorta as a sort of a 2D non-functional pipe because that's the only tools that are available to us at the moment. What the virtual aorta is going to do is help us to bring biomechanical factors into day-to-day clinical practice.
At the Insight SFI Research Centre for Data Analytics, we perform high-impact, world-class research to enable our society and our citizens and our industry to make better decisions. We're bringing together expertise in all the different areas in AI and data.
What you have is very large files, hundreds of gigabytes for like a full CT scan, perhaps.
That we want to look at things like pulse wave velocity, shear stresses, all of those are biomechanical properties of the aorta. It takes about 150 hours in a supercomputer.
What we were looking to do is emulate that process, make a surrogate model essentially, run through AWS in real time in order to reduce that down to perhaps 30 seconds.
One of the challenges that we have is in the area of skills. So our partnership in Okra funding, Rackspace Technologies and AWS has given us access to skills and to trainings to ensure that our data scientists and our data engineers are appropriately skilled and can work with our industrial partners and our societal partners.
The relationship with Rackspace is fantastic. Rackspace has been offering kind of the formal training that we would be looking at. So specifically around architecting proper frameworks for such a project like this.
Rackspace have been very influential and very helpful in helping us onboard AWS Tech.
Okay, I might pause it there in the interest of time. It does get a bit commercial and promotional at that point, rightly so, because they were funding the work. But I think it's a great example of academia coming together with large industry and a local supplier through the mechanisms of European open science, which is a real win-win-win for everyone, in my opinion. So thank you very much for your attention. As I say, we're here. We're looking forward to collaborate with your community, and I look forward to the follow-ups as a result of today. Thank you very much.
Thank you so much, Noel, for bringing that whole area of big data, analytics and AI into the conversation today. Our next speaker, our penultimate speaker, is Professor Inez Thiel, who's a leading figure in systems biomedicine at the University of Galway. Inez plays a pivotal role in advancing the concept of digital twins in human health. Her work bridges biology, computer science and clinical medicine, making digital twins a powerful tool for precision health. Welcome.
Very much. Thanks to Fidelma and everyone for inviting me and giving me the opportunity to present one of our projects today that we're doing in the bigger scheme of digital metabolic twins. And here we're actually addressing inherited metabolic diseases. Now, inherited metabolic diseases are single gene deficiencies, enzyme deficiencies, and individually very rare, but collectively the 1,700 to 2,000 inherited metabolic diseases, depending on where you're looking, affect between 1 and 100 to 1 to 2,500 life births worldwide. So they are very frequent. About 275. So again, between 10 to 18%, depending on the total number of IMDs, you're talking about are treatable. The rest are not treatable. In most countries screen for inherited metabolic diseases, but again, the number of screened inherited metabolic diseases varies dramatically between the countries. between 8 to 50, depending where you're looking at. And the reason, or a key reason for that, is that generally we only screen for those diseases that we can treat and we have a prognosis for. So there's an utmost need to better identify disease, to find therapeutic avenues, and then also provide the families, the caregivers, but also the patients with a prognosis. Now, the challenge for inherited metabolic diseases, because they're very rare, is that in the first instance, only there's a very low diagnostic yield, and it can be as low as 20 to 70%, depending on the disease. Traditionally, they've been diagnosed on blood spots, only metabolomics. Nowadays, more frequently, also due to genetics, either genome panels or whole genome sequencing. And nevertheless, the diagnostic yield remains low. And so we believe that the digital metabolic twins that we've been developing over the last decade or so in the laboratory can help to accelerate diagnosis and then also the therapy finding. But what we need for that are biomarkers, reliable biomarkers that help you to identify the disease, but also then to actually design treatments and clinical trials, targeted clinical trials. So how is a biomarker, particularly blood metabolite biomarker, affected? Well, needless to say, the genomics plays a role, but then also diet. The alcohol only is relevant if there's not an infant we're talking about, but a later onset disease. The microbiome, this hasn't been investigated to a large extent yet, and both affect the metabolome that we're looking at for the biomarkers, but also the disease phenotype. Where there are single gene deficiencies, they have a widespread spectrum of clinical features and phenotypes. So really to distinguish the different subgroups and their needs is really important. So we do that through metabolism, and the field of systems biology has built comprehensive models of human metabolism since 2005, first published in 2007, and we have continued to do so over the last almost 20 years now. And just to give you an idea of how far we come, I take a picture of a good friend and collaborator here of mine, Cyril, that I'm grateful for him donating his mugshot here. And he overlaid the resolution of the first version we published in 2007. Then the follow-up further refined metabolic models of the human in 2013, 2018, and actually in 2020, we have a whole body model developed, which really on an organ level comprehensively captures whole body metabolism and their interactions between the organs on a metabolic basis. Now, on the left-hand side, I actually show you this, this left-hand side, I show you this whole body model, a sketch of this. And so this can be personalized using clinical data, but also various omics data. But really, if you wanted to look into IMDs and the diagnosis and early detection and treatment, you needed a digital baby, if you want. And so Elaine Soundseder, a previous PhD student in collaboration with collaborators from Heidelberg, developed a digital metabolic baby, a male and a female, which represents, as far as we know accurately, the metabolic specialities as well of babies, including thermoregulation, the energy balance, water balance. So now we have a baby model for each day of growth of a baby and infant from day 0 to day 180 that we can use. And so in order to develop novel biomarkers that are reliable and reproducible, we decided to start with a very well defined and characterized inherited metabolic disease, and that is phenylketonuria. And so we can take the day 2, generally the heel prick dry blood spots are taken on day 2 from the baby's day 2 baby model to predict biomarkers. And so we did that across board for hundreds of metabolites, and we found very spurious results, which we couldn't really explain, but also we found the obvious candidates. For phenylketonuria, of course, you would expect an increase in blood for phenylalanine due to the blockage of the enzyme that step from phenylalanine or L-phe to LTF. So that's the enzyme that's defective. And so you have phenylalanine increasing as well as downstream products of phenylalanine. At the same time, we predicted using the normal baby models, which are germ-free, that tyrosine would be decreasing and tyrosine derivatives. Now, if you look into the literature and you ask clinicians, you will find different answers. That is that some babies have a normal level of tyrosine, while other ones have indeed dramatically reduced tyrosine levels. Now, tyrosine is interesting because it's a precursor for neurotransmitters, and so hence a lot of neurological consequences of an untreated phenylalanine ketonuria is actually caused by not by phenylalanine accumulating, but the deficiency in tyrosine. So identifying those individuals that have lower levels of tyrosine and treating them accurately, we found interesting. However, our model can only give 1 point. That is, there's a deficiency in tyrosine predicted. And that does not represent the natural variation of infants. There are 2 explanations or 3 possible explanations that could further alter the tyrosine levels. One, of course, is host genetics that might have alternative or additional mutations that may increase or decrease the tyrosine level. Diet is another one. And finally, the microbiome. And so we decided to follow up the microbiome. And as we have developed comprehensive digital metabolic twins for human metabolism, we also have that for hundreds of thousands of microbes. So we thought that's a good starting point. And so we can actually take our in silico babies and impute personalized microbiome communities in silico in those babies in the large intestine, and then ask the question, well, what is the consequence of having a distinguishable, diverse microbiome community present in the large intestine, and could that affect both phenylalanine and tyrosine levels? So we took as a proof of concept, and in the absence of data for PKU patients, we took healthy babies around the age of 2 days whose metagenomic data have been published. Again, for simplicity, we only focus on females. And all I want to show you here with this plot is that these microbiomes are very diverse. So suiting our purpose of wanting to have a good assessment whether the tyrosine is indeed reduced and whether it would be a reliable biomarker for PKU in addition to phenylalanine. Just to give you some numbers, the baby models themselves are about 80,000 metabolic reactions. Now with microbiomes, we're talking about 200,000 upwards metabolic reactions. So we're really comprehensive in terms of metabolism. So we repeated the predictions we did beforehand by knocking out the phenylalanine hydroxylase, and what I show you in the green box is basically that even with the micrograms of 48 present, the increase in phenylalanine remained statistically significant from healthy and disease. The only difference between these 2 babies and silico babies is their microbiome composition. Everything else is identical. And of course, having PAH knocked out in the disease case. And so the diet is the same, the metabolism otherwise is the same, so it's all identical. Any change you see here is due to different metabolic activity of the communities that we imputed. Similarly, all the derivatives of phenylalanine remained statistically significant. So that's a good positive control for us. It is a robust biomarker. It is used every day in clinical practice. So the microbiome does not affect it in silico either. It's a good biomarker. So now what about tyrosine and its derivatives? So tyrosine itself stayed significant when you knocked out the PAH gene. However, all the other derivatives of tyrosine, including L-DOPA and dopamine, did not survive the variation, or basically they were statistically not significant anymore, underlying what's been reported partially in the literature. So when we looked at it a little bit closer with L-tyrosine, and you can see it yourself, that actually the p-value was driven by a few outliers. And in fact, 11 out of the 48 had lower tyrosine levels, while the other ones were the same as the healthy models. So something is different in these 11 microbiome communities. And since we have mechanistic models, not statistical models, not AI models, but models, computational models based on biochemistry and microbiomes in this case, we can actually look into which microbes are statistically less abundant in those 11 cases. And we found 6 microbes, including 5 bifidus, which could serve as probiotics, to be less abundant in those 11. That would explain the reduced tyrosine production levels in these babies. And we could even further drill down and ask the question, what are there certain metabolic pathways that are relevant? Now, just to give you an overview, there are 3 possible microbiome ways to produce tyrosine, which is shown on the right-hand side. And we found that actually in the 11 microbiome communities, there's an underrepresentation of the upper pathway, that is the ergonate or pre-tyrosine pathway. And so these are the data to that. So we have a relative reduced abundance. So that gives us a first handle of what is missing and how could we actually, not only using probiotics, but maybe also drug treatments to restore the tyrosine levels in those individuals. When looking a little bit further into the characteristics of these microbiomes, we found that there's an enrichment of cesarean-born individuals that actually corresponded to those low abundance microbiota carriers, if you want to call them that way. And so what would mean for me as a suggestion is, well, check those individuals born with cesarean that actually test positively for PKU for their tyrosine levels first, and they may actually need much more supplementation than the other ones. So our vision here is really to use our digital metabolic twins, both for the adults as well as the infants, for identification of subpopulations and ultimately for targeted clinical trial designs to identify potential biomarkers and endpoints, and also guide the trial design itself, and then of course perform the validations. And with that, I would like to thank you for your attention and a great team to work with, both here at the University of Galway as well as in Germany, for the collaborators. Thank you very much.
Thank you so much, Professor Thiel. I'd now like to introduce our final speaker for this afternoon, Professor Andrew Murphy. Professor Murphy is practicing GP in Turlough in County Galway, and also Professor of General Practice at the university here and Director of the HRB Primary Care Clinical Trials Network Ireland. He has recently been awarded the Health Research Board Impact Award for 2025. A distinguished contributor to the field of clinical research, we now hear from Andrew on the important role of GP participation in clinical research, decentralised and community-based trials.
Thank you very much indeed, Ruth. Thank you indeed. And thank you to Fidelma for the invitation as well. It's been a really busy and productive day. So I hope you'll let me take 30 seconds just to a little bit of nostalgia and also just to reaffirm as to why we're all here. I've taken a little bit of a risk in this in that I have not presented sort of successful trials that we've done. Fidelma wanted us to look forward, so I'm presenting trials that are currently recruiting and another one that we hope will about recruit soon. Last week was nostalgic for me because I finished the last tasks that I had as executor of my parents' estate. As far as the Internal Revenue Service of Ireland is concerned, my parents are done and dusted. This is my favourite picture with my father in 1971 on the golden waters of Lough Swilly. But I'd like to think that their legacy continues on a little bit. In cleaning out the house, this is my father's clinical notebook from 1944 as a medical student at the Royal College of Surgeons in Jervis Street, the shopping centre many of you might know it as. Very serendipitously, I think there's a lovely arc from the first talk that Patrice gave this morning, because I opened the notebook on the treatment of acute myocardial infarction, best practice in 1944. There are 3 things to learn from this notebook. First, the standard of medical handwriting has improved dramatically over the last 80 years. Secondly, the presentation of clinical symptoms and signs would stand aloof with anything that Patrice is taking from his patients at the moment. It's absolutely spot on, the history taking. Alas, where things fall apart is in management, as we would expect. I've circled in red there in my father's handwriting, which only I can read, as to what was the treatment in 1944. The treatment was complete rest in bed. The longer, the worse. The longer for the most difficult situations. A minimum of 6 weeks is recommended. We are here because we believe in the production of high quality evidence. Poor quality evidence does not just waste resources, it kills. 18 years after my father wrote this clinical note, his own father, my father's father, who I never met, had his significant heart attack. And he died 2 weeks later in his bed in Wexford from the massive pulmonary embolus that we all know would occur. And that was the treatment and the outcome for millions of patients. So I think just to remind ourselves after the busy day we've had, the production of high quality evidence is absolutely priceless and saves lives. And it's really important that I'm not in any way impugning the care provided by the doctors to my grandfather at the time. They were simply providing the best care that they knew according to best standards. They didn't have guidelines like Bill McAvoy has produced, but they were doing the best they can. It's just so important that we continue to produce evidence. This is my clinical world, Turlockmore Medical Centre, about 10 miles northeast of here. That's my favourite picture of the practice on the bottom there, February 22nd, 2021, when we, about 8 o'clock at night time after we'd finished our first ever COVID clinic. 497 patients invited in chronologically on software that we'd never used before. It was just amazing to see on that. And if that isn't the whole COVID stories we've heard, what a great innovative story. But in Ireland, every single year, what I want to highlight to you is the huge potential which is untapped in general practice and primary care in Ireland. There are 22 million consultations every year in general practice in Ireland. There are an additional 2 million out of hours consultations, and 99.9% of these are electronically recorded. I have not written a paper note in over 20 years. Unfortunately, these are largely siloed, but one of my final slides will highlight how I think we can start to link these a little bit together. And I'd like you to pay particular attention to the 1,700 chronic disease management consults that occur every day in Ireland. This is a new initiative from the government. Up till now, in general practice, one of the great intellectual challenges was we never knew what was coming in the door. Every year for certain conditions, heart disease, diabetes, COPD, the government will pay for patients to visit twice a year to their general practitioner to see a practice nurse and a GP. So we can now proactively identify certain types of patients coming in, which is an absolute boon for recruitment to clinical trials, which I hope to highlight in a few minutes. Very short description of the HRB Clinical Trials Network, which I'm very privileged to lead. It was first funded in 2015. As you'd expect, our mission is very much about high quality evidence. There's 4 different arms that we do. The trials we've supported over 40 trials at this stage, over 4,000 patients.
been involved in trials that have been published in New England Journal, Lancet, the normal sorts of things. Spent a lot of time capacity building. Ireland has a relatively small number of clinical academics and an even smaller number in general practice. The great Sir Derek Stewart was mentioned earlier on this morning. He has really supported us in our public and patient involvement in all aspects of our studies. But the bit I'd like to highlight for you, because it may be of interest, is research prioritization. We've really had a sense today, I think, of the importance of patients in the whole research journey, as really emphasized by Siobhan. We partnered with the James Lind Alliance to develop primary setting partnerships to formally go about asking what are the priorities of patients in certain areas. And the areas we chose was chronic disease management because it's so intrinsic to the bread and butter of general practice. The resultant paper is at the bottom there, and this was our final group that we got together. There's a very formalized system going through the production of these priority setting partnerships, but I think they should be very helpful to all researchers and being able to say, yes, we've listened to patients, and in actual fact, there is a prioritization exercise that highlights these important points. There should be an extra box at the bottom of this. This is James Lind Alliance. The next box should be dissemination. And we've spent a lot of time in dissemination to the extent that only last week we met with the Health Research Board, who've agreed to include research prioritization as part of their guidelines for the submission of research trial submissions. So if there is a research prioritization in your area and your research area hits that, that will help your application. Just to give you an example of the first one, look at the first, and this is from patients and their carers. What do they think is really important in the management of chronic conditions? Number one was, how can the exchange of information be improved between specialists and general practitioners? Patients are amazed in Turlockmore, 10 miles from here, is that I've quite a number of shared patients with Bill McAvoy. I take bloods. They're on the hospital system, and it's easier for them to call into our practice, for us to print them out on paper, and for them to bring the paper into University Hospital Galway. It is easier to get a man on the moon than it is to get blood results from general practice into the hospital, even though they're stored on the hospital. This is absolute madness. Moving on quickly to the exemplar trials. This is a patient who is very typical of what we're seeing in general practice at the moment. She suffers from multimorbidity. A great landmark paper in The Lancet by Barnett highlights that multimorbidity, the presence of 2 or more conditions, in absolute numbers is actually higher amongst younger patients than older. It is a huge epidemiological issue. Very complicated history, and like 15% of all over 65-year-olds in Ireland, she is on 10 or more medications. Polypharmacy and multimorbidity are 2 of the real pressing issues for us. A great colleague, Susan Smith, who I've worked with for a number of years, led an award from the Health Research Board to look at patients with multimorbidity and what could we do for them. I was really delighted to hear Max's endorsement of multi-arm trials. I don't know what I would have done if he'd said they were useless, but here we go. This is the first one that I got involved with. And as Max said, it sailed through the reviewers, sailed through the ethics. It's the only time from a reviewer's point of view that I've been involved in an application in which the reviewer said, as a multi-arm trial, you should give these guys more money because they've set the whole thing up. You should just keep funding them, which I thought was a great idea, but unfortunately the HRB did not take that on. It took us 2 weeks to recruit 16 patients in Turlockmore because we were able to piggyback onto that chronic disease management program. We were able to look at what patients are booked in, have they got multimorbidity, are they on 10 or more medications, and back to sort of personalized medicine. Many of these patients I would have taken care of their children and their grandchildren. There's a great relationship in general practice to patients, so that we were able to identify which patients. The 2 arms that we had was provision of a pharmacist for free to a practice for 6 months to look at all those medications, and then accepting that there's more to life than medical, to look at social prescribing. Is the availability of exercise programs, additional social welfare payments, will that make a difference? And the outcomes, again, were very much influenced by a public involvement panel. They wanted to look at things like mental health, which they viewed as hugely important, not just looking at hemoglobin A1Cs. So that was what was involved for a practice. We had a waiting list of practices to join this trial. because of the perceived relevance to their patients. I accept entirely the offer of a free pharmacist for 6 months for a session might influence things as well, but that to me is exactly what we're trying to do. We're trying to have relevant trials here. You can see the monetary bits that we gave. In our experience, the key aspect for GPs to get involved in trials is actually clinical relevance. Does this going to make a difference to them? The money is secondary. They do not want, it's a private business, they do not want to lose money. So as long as you can be sure that you can at least cover costs. I do not want to oversell this. General practice is not going to be a successful hunting ground for rescue trials from hospitals. We've tried it, it doesn't work. These have to be very light touch for practices as well, but there definitely is a niche there for them. As I said, we've got really good national recruitment. We've recruited all our practices. We're well on the way to recruiting all our patients. Takes a bit of time from when a practice pulls up, and we're on target for recruitment. So personalized medicine, looking at chronic disease management, I think is helpful. Let's look at decentralized models. Yesterday, I had a patient who I've known for 15 years. It took her 10 years to tell me that she suffered from significant urinary incontinence, a really embarrassing, difficult condition, 6 to 7 times a day to the bathroom, twice at night time. Medications haven't worked, and she's on a waiting list. She doesn't have private insurance, so she's on a waiting list for both hospital and physiotherapy as well. A good story for Galway is this study is Amara, which is a spin-out company from BioInnovate, and it's the first time we've worked with Enterprise Ireland as well. And this is an app which is immediately available to patients. It's downloaded by them. It provides immediate access to care, holistic treatment, both behavioral and physiological. It gives them set targets for themselves and has shown promising results in a pilot stage over 8 weeks. And we're trying to pilot that in Ireland. It's CE certified. And the clinical site is entirely virtual. We will not see these patients at all. They will download the app and they will download outcome data onto their phones. We could not do this if it were not for the clinical research facility, which are setting up all the facilities for this, including online consent processes. Again, something I've never been involved in before. It's a direct-to-patient trial. I've never been involved in this before. We will promote through our GP networks, as we always do, but we're going direct to patients through print media, advocacy groups, and for the first time ever for me, paid social media. And again, we wouldn't be able to do this without Niamh Connolly, who was instrumental in organising today's conference, will be helping this for us as well. I was concerned going to NRAC as to how they were going to perceive this. I've had more blowback on a questionnaire survey to GPs about attitudes towards chronic disease management. They gave very good advice and turned it around within a week. So again, I do think that the regulators are very aware that for a low-risk trial like this, I think it is reasonable to adopt these sorts of approaches. So just looking at the future, how are we going to untap those 22 million consultations every day, which are siloed at the moment? At the moment, when we go to practices, we have to go to them individually, and they have to try and identify the patients for us. This schema developed by the Clinical Trials Network, I think, points a way towards the future in that, and it's based very much on the UK model, Max, of a trusted research environment in which that we will be able to anonymize the data, send it to a trusted research environment, perhaps the Central Statistics Office, perhaps the Health Intelligence Unit in the HSE, in which there will be a governance structure which will ensure that there are safe projects that are vetted, safe people, safe management of the data, and then safe outputs from it. We've been banging this drum for quite a number of years and, being honest, have made relatively little progress in trying to progress this, mainly because I think the software systems were not that, and there's only one owner of them, were not that interested in trying to pursue this agenda. That has completely changed now. And as a naive optimist, I do think that we will achieve this within 5 years. And one of the main reasons I think we will achieve it is because of patients. Patients just cannot understand why I have to print out those blood results and for them to carry them into hospital. Equally, they cannot understand that we are not linked directly into the hospital. We're not directly linked into the cancer registry. They absolutely see the benefits that can accrue from it. And I do believe that this will be achieved, and it will be achieved not on the back of sort of reports that we will be writing a report on it, but I do think it'll be patient power that will very much push this towards the future. So conscious of time, I think I really want to emphasize to you that the vast majority of Irish healthcare, 22 million consultations a year, occurs in the rich electronic landscape of Irish general practice. The potential for trials to transform both general practice and Irish healthcare is absolutely enormous. And I do think that the enabling landscape that we've heard all about today at University of Galway will be a key lever to achieve this. And I would like to acknowledge very much Laura O'Connor, who led on our James Lind Alliance, Ruand Kane and Sarvina Bumatan, who's very much involved in the Resolve trial as well. Thank you very much indeed.
Thank you very much, Andrew. Now, we are going to try and squeeze in a few questions. So if you have any questions for any of our speakers this afternoon, I'd ask you to raise your hand, and just in the interest of time, maybe we'll keep your question concise. Again, it's hard. We've obviously the talks. Oh, Fidelma has a question. Fantastic. I think we have a microphone on the way down to Fidelma.
If I may, I'd like to ask Andrew, is there any problem with patient consent to use their data collected by general practitioners in good faith through secondary data analysis to answer another research question?
So as ever, it depends a little bit on what question you're asking. If you're asking about collected data sets for certain research purposes, which can be absolutely anonymized, there is no problem on that. Where the difficulty comes in is in at the moment in say in my practice, which would be very typical of others, we have huge amounts of free text data within the files, which cover up from age 0 to whatever. So it's very difficult to predict what sort of data is in that. What the schema that I've put out there is that there would be a very formal system of absolutely de-anonymizing data, so it can't be linked to the practice or even to the locale. And that's, I think, where we will all benefit as trialists, in that in the UK, they have a very well developed system through the NHR of being able to say, we're running a study in Parkinson's, we want people who are over the age of 50 with Parkinson's disease, and they can do an immediate search of England and identify those patients, and then move towards remote contacting of them, Fidelma. So I am optimistic about Ireland. As I said, I think it will be happening soon, but not today.
Thank you. Question here at the back. Derek, is it? I can't see it.
Derek Stewart, cancer patient many years ago, but now wearing an Ireland Medtronic pacemaker. So thank you. Just an observation. I came to the launch a few years ago. The progress you're making is fantastic. To hear the speakers here today, the rich development of work they're doing, the research they're carrying out, and the way they're working with each other was beyond the imagination when this was set up. So just say thank you to all of you.
Oh, thank you, Derek, for those words. And I know from talking to you that your advice has been a big part of driving that success. So thank you very much. Today has shown us, I think, what's possible when we share insights across sectors, disciplines, and countries. The future of trials is collaborative, adaptive, and focused on real-world impact. Over the course of today, we've explored new ways of doing clinical trials, from the visionary to the very practical, the disruptive to the deeply human. And what we've seen here today, I think it's not just the future of trials, but the future of how we deliver better, smarter, and more inclusive healthcare. The dedicated team at the Institute for Clinical Trials here in Galway believe that collaboration is the engine of progress, and I think that has been echoed over and over again as we've talked today. What begins in rooms like this can reshape how trials are imagined, designed, and delivered. So I suppose our call to action is let's carry this momentum forward. Let's keep up the dialogue. Let's strengthen our partnerships. And most importantly, take action and develop the connections that you've made today. On behalf of the organising team, I'd like to say thank you to our partners, particularly Medtronic, and to our fabulous speakers and panelists. Your insights and energy have sparked conversations, the networking was fantastic, and I know some of those will continue long, maybe into the evening and beyond today. Special thank you to those who presented the patient voice throughout the day. I think those have made a really big impact on everyone who's been here. And to you, our attendees, thank you for bringing your expertise, your curiosity, and your ambition to the room. I'd just like to say this conference could not have happened. They've been working away all day in the background without Elaine Breslin and Niamh Connolly and their teams. It's been an absolute privilege to work with them and with Fidelma Dunn today. So could I ask you please to give them a round of applause? We look forward to continuing this conversation with you in the months and years ahead. Stay ambitious, be brave, and safe travels. And thank you all for being here today with us at Future Trials 25.